First, I would like to talk about how to diagnose about a case of a post-Lasik ectasia, starting from identifying the major risk factors and knowing the definitions, knowing why it happens, and how to find a case of a post-Lasik ectasia. For disclosure, I have no financial interest using the corneal mapping in this presentation. To start with, what is a post-Lasik ectasia? I read many studies about defining the post-Lasik ectasia, and there has been many features defining this devastating complication. But one of our famous professors, Randleman, in 2008, defined post-Lasik ectasia in 3 ways. The first one is finding the asymmetric inferior steepening of 5 diopters or more compared to immediate post-operative topography. So this is very important to document the post-Lasik keratometry in the first few days to keep it for the follow-up. The second item is the loss of 2 or more Snellen's visual acuity along the whole period of the follow-up, and the change in the manifest refraction of -2 diopters spherical equivalent either in the sphere or the cylinder. And the incidence, I have read that the incidence may happen from a few weeks, starting from a few weeks up to several years, with a median time of 12 months. So some definitions or some concepts to know. Post-Lasik ectasia, it is an iatrogenic keratoconus. So if you miscalculate or you mischoose one of your patients, you will do him a keratoconus. He's coming normal and you will do him a keratoconus. So it is a progressive and it needs to be stabilized, and the surface needs to be regularized as well. Post-Lasik ectasia, it is a post-myopic regression, not progression. This was a question I was asked in my master's examination. I didn't know. Myopic regression, it is loss of the effect of the laser, which means that the keratometry starts to rise again. While progression, it is the progression of the myopic pathology itself, whether the chorioretinal degenerations or the axial length lengthening, and so on. So post-Lasik ectasia, I think it's well known to all of us, especially among my professors, of course. But why it's important to repeat it? Because I've read a news that one of the US Olympics had a post-Lasik ectasia, and he wrote a book about it. So I just hope no one in Egypt write a book about this procedure. So we have to be careful. So why it happens? First, we have to know the criteria and risk factors that might predispose to post-Lasik ectasia. Second, I'm going to talk about multiple ablation depth calculation methods to get the safest results. And finally, the pre-ectatic conditions. So coming to the criteria that might predispose to post-Lasik ectasia, Randleman again in 2008, he proposed an ectasia scoring system, and he was mainly concerned about 5 items. First, it is the topography with the different topographic patterns. I'm going to go through each one. The residual stromal bed, the age, central corneal thickness, and the manifest refraction spherical equivalent. And when we calculate the spherical equivalent, I see some add half of the cylinder value to the sphere. I think it's for the safety, and it's the right way is to add the whole cylinder value to the sphere value. By finding the score, we can decide whether not to do anything, whether to do BRK or whether to do LASIK. Another system was proposed by Dr. Mazen Sinjab in the past week. He showed it to us. He was especially concerned about the anterior mean keratometry and thinnest location of the cornea, anterior sagittal map, elevation maps based on the best fit sphere and the best fit toric ellipsoid, the corneal thickness map, and the thickness profiles. For each one of this item, there is a normal and the abnormal shape or the abnormal values, and we're going to demonstrate these in a moment. So, for example, this is a pentacam with the 4 maps. These are the 4 main maps. Usually, in the pentacam, we have the Bellin-Ambrosio. Most of people rely on it, but I find that, or many professors find that The Bill and Ambrose is just like a supporting evidence, but the main maps to diagnose a keratoconus are these 4 maps. So we're going to go through these maps. First of all, the anterior sagittal map. We're not going to say how to read a pentacam, but we want to know how to assess the cornea regarding the risk factors we mentioned before. So regarding the axial sagittal curvature map, as was proposed by Randleman, you have to be concerned about abnormal shapes or abnormal topography. So the first thing to comment is the shape. What is the shape of the sagittal map? The difference between, it is important to find the difference between the keratometry at the 4 millimeter down here and the keratometry and the 4 millimeter up here. Whether there is an inferior steepening or superior steepening, because some maps, by looking at the color, they may look like they have an inferior steepening, but if we calculate the numbers, there is no inferior steepening. We call it an inferior steepening when these 2 numbers, the difference between them is 1.5, or we call it a superior steepening when the upper keratometry is higher than the lower keratometry by 2.5. That's when we can call it a steepening, but we don't have to look on the color only. We have again to look on the topographic astigmatism and versus the manifest astigmatism. Regarding the abnormal shapes, we can find the inferior steepening, and the one to the right is the skew axis deviation, which means that one of the bow ties is skewed by more than 25 degrees. We find the superior steepening and the joke low, and these are other abnormal shapes that we can encounter. Regarding, I cannot see this. Okay, regarding the pachymetry map, we have also to comment on the shape, the difference between the thickness points at 5 millimeters up and down. We can find the angle kappa, not really, but it's better to find it in the Placido topography. But we can find the angle kappa by finding the values between the pupil center coordinates x and y. The thinnest location displacement is important, and the Kmax normally less than 49. It is important to stress on the thinnest location displacement. Thinnest location displacement takes always a sign of a circle, and you have to compare it with the pachy-apex on the y coordinates. Normally it is less than 0.5 millimeter. From 0.5 to 1, it's a suspect. More than 1, maybe it's a keratoconus. These are the abnormal shapes of the pachy-apex. This is the dome shape with the thinnest location displacement, and this is a bell shape when there is usually an inferior thinning, comes with the PMD, and this is a globus. Regarding the elevation maps, we have also to comment on the shape and the elevation numbers. And the elevation numbers, we have to look on the reference image that was used, which is the best fit sphere or the best fit toric ellipsoid. If it's a best fit sphere, we have to know whether he is myope or emmetrope or mixed astigmatism or hyperope, because each of these values have different normal and abnormal values. And if it's a best fit toric ellipsoid, so whatever the refractive error, the normal and the abnormal values are 12 and A15 for anterior and the posterior, respectively. What about the abnormal shapes? Abnormal shapes in the elevation map, posterior elevation map, we can have an isolated island, a tongue-like extension, a skewed hourglass, and a kissing bird. Regarding the upper 3, we usually can see these images in a normal cornea sometimes, but we have to repeat the pentacam. This is maybe due to misalignment, due to tear film abnormalities. So we have to repeat the pentacam, and we have to correlate it with the elevation, which means that in this case, there is a tongue-like extension, and at the same time, there is a central elevation, plus 79, which is a high number. Regarding the thickness profile, we have the percentage thickness increase and the corneal spatial thickness. The curve has to be within the dotted lines, within the normal range. And the average of the progression index have to be from 0.8 to 1.1. So what are the abnormal shapes that we can see? Either it's a flat curve, but a flat curve is out of our talk now. It comes with the Fuchs dystrophy and the corneal edema. We have to stress on the S-shaped and the steep curve. S-shaped and the steep curve that comes with a high average progression index like 2.3 is usually encountered in the corneas where there is a rapid change in the thickness concentric around the sinus location. We can see it in the post-myopic ablation, or we can see it in the keratoconic or the ectatic disorders. Regarding the Pillin-Ambrosio, we have to understand it. Usually in the standard elevation maps in the first page, the elevation is usually calculated using a standard best fit sphere, which means that I take a standard sphere and compare it to the cornea. The disadvantage of this method is that it could be affected by a cone of a keratoconus. So the standard best fit may be steep. And in this case, it will hide part and mask part of the cone under the red line, under the yellow line. So the Pillin-Ambrosio have an enhanced system by subtracting this part with the cone with the highest elevation. We have to subtract it from my equation, and then I have to create another best fit sphere outside this 4 millimeter zone, which will be more flat. Then putting back the cone and calculating the elevation. So we can see that the difference between the left and the right image, it is a part under the yellow line. I'm running out of time, so I have to go quickly.
No, go ahead.
Okay. So this is an example. Okay, the first two images on the left, these are the standard elevation maps, which means these are the elevation maps created by the standard non-individualized best fit sphere. So we can see the numbers +17 posterior and +3 almost, or +19 anterior. Okay, in the enhanced or the exclusion elevation maps, the corneal elevation value are assessed using the enhanced best fit sphere. So logically, we will see that the elevation is higher because the part that is unmasked, it is the part that was masked by the standard sphere is now unmasked. So we can see the numbers rise to +76 and the anterior one to +30. So the last two maps down, it is the difference between the best fit sphere and the enhanced best fit sphere. And the difference is classified into three. The normal with the green color, less than 12 microns, borderline cases from 12 to 16, and more than 16, these are highly suspicious to be keratoconus, or more likely to be a keratoconic case. So it is only a supportive evidence, especially when we have a borderline cases. So moving to the next part, the ablation depth percentage calculation. Usually, I've seen many doctors, and me myself, I use multiple equations while going for the stromal ablation. The famous Monreillian formula, by knowing the optical zone I'm going to ablate and the intended correction, this will yield a result. Then I have to use another equation. The residual stromal bit should be at least 55% of the sinus location of the cornea, which means from 250 to 170, maybe up to 30. And the ablation depth should not exceed 20% of the sinus location of the corneal thickness. This will yield another number. By the first three equations, I have to take the average or to take the safest result I can get. And I don't have to forget to revise again the ablation depth on the machine I'm using, because it will always be somehow different from my calculations, especially when I'm doing a wavefront guided topography that usually adds more ablation depth due to corrected high order operations. So what other risk factors we can see? Of course, pregnancy and hormonal instability, we have to keep away from these patients. Post-Lasik adenoviral keratoconjunctivitis. I have read some studies that adenoviral keratoconjunctivitis post-Lasik can predispose to ectasia due to weakening of the collagen fibers. There is a pre-ectatic condition like the form of rustic keratoconus or the keratoconus suspect. They can predispose to post-Lasik ectasia. Of course, keratoconus, no one will Lasik these patients. Poor keratomes, because poor keratomes or the reusable keratomes they can yield wrong calculated Lasik flap thickness. If it was intended to be 150, it can give you a 170 or 180. Post-operative rise of the intraocular pressure, systemic connective tissue disease, and the wrong calculations as we mentioned before. So there's another confusing issue about defining the form of rust keratoconus suspect and the clinical keratoconus. Well, I find so many definitions, but I think form of rust keratoconus, I will call it for the fellow eye with a keratoconus or a strong positive family history. That means that the eye is completely normal topographically, tomographically, clinically, but the other eye has keratoconus. So this is called the form of rust keratoconus. A suspect case is normal clinically, or it is a subclinical keratoconus. It might have a normal placido topography, abnormal placido topography, or corneal biomechanics, but it yet didn't meet the full criteria of a frank keratoconus. For example, we can see in a suspect case thinning with abnormal topography, but yet we didn't see a posterior elevation. So it did not meet the full criteria, or the thinnest location displacement is not full yet. We can see a difference between the both eyes and the thinnest location and the Kmax, but yet it did not become evident clinically. And the clinical keratoconus, we all know about it. So these definitions, these are the sources for the definitions. For example, this is an example of a case of a form of rust keratoconus. The one on the right, we can see a normal symmetrical bow tie with an average numbers of the anterior and posterior elevation +6, +2, and the corneal thickness is okay. While the other eye, we can see the thinning, the tongue-like extension with the posterior elevation, anterior elevation with the isolated island, and we can see in the sagittal curvature map an oval-shaped cone of a keratoconus. So how to catch a case of a post-Lasik ectasia? Clinically, as we defined it before, we have a progressive decrease of the uncorrected and the best corrected vision. The patients start to complain of high-order aberrations such as the glare, ghost images. There is again a progressive increase in the myopia, more than 2 diopters, whether in the astigmatism or the myopia. And we can have a slit lamp appearance of a case of a keratoconus because they have the same pathology. Topographically, we can see a progressive cornea thinning, progressive inferior steepening of more than 1.5 millimeters. There is an increase in the mean keratometric readings, increase the posterior elevation and the anterior elevation of the best fit sphere. And the Q value, we can see a high minus values because normally post-myopic Lasik ablation will normally yield a plus Q value. If we see a high minus value, this is again a diagnostic criteria. Regarding the wavefront analysis, the most devastating feature of the post-Lasik ectasia is the high order aberration represented in the corneal coma and astigmatism and the defocus. These are the Zernix polynomials of the coma and the astigmatism and the spherical aberration, with the most devastating one which is the corneal coma. Because in the corneal coma, we can see that we have almost like 3 slopes along 1 meridian. And in the spherical aberrations, we have 4 slopes. So how to assess the wavefront aberrations? There is a lot of parameters. The most important is the root mean square, which is an expression of the physical surface of the shape of the wavefront deviated from the perfect wavefront. Usually it is less than 0.3 microns. So in the case of a post-Lasik ectasia, we can encounter either a defocus alone or an astigmatism or a coma, or we can have all 3 of them in the same patient. So this is a case of a post-Lasik ectasia, for example. We have to check the following. First of all, the Q value is minus 0.32, which is not expected. The topographic astigmatism is 2.5. We have corneal thickness 451, and we have to compare this thickness with the intended post-operative thickness according to my calculations to see if there was thinning or not. We can see an inferior steepening And we don't forget to subtract this 48 from the 40. So we have an 8 millimeter, 8 diopters of inferior steepening. In the 4 millimeter zone, we can see like a tongue-like extension with an anterior elevation plus 19, and in the posterior elevation we have a tongue-like extension with posterior elevation of plus 34. So all of these are diagnosing a post-Lasik ectasia, along with the history of LASIK, of course. The most important factor is a patient coming complaining of glare. If I see this pentacam without a history, I can go for a keratoconus. This is the Bellin-Ambrosio. Usually the Bellin-Ambrosio and the post-Lasik cases, they are not reliable because all of the readings are abnormal. But at least we can use the one in the bottom on the right for follow-up only. This is a wavefront using the Schwind series. We can see that the high order aberrations is 2.3 microns. The most devastating one is the astigmatism, 3.3 microns right here. And the coma is about 1.63. This was the other eye of the same patient. It did not have any ectasia, as we can see. There is an area of a central ablation covering the whole pupil center. There is no steepening, inferior or superior. And by the way, it is usually the post-Lasik ectasia is with inferior steepening, but I don't know, maybe my professors will let me know if there are other patterns of the post-Lasik ectasia. Maybe you can see a central cone, or maybe you can see a superior steepening. I don't know about this. Here is the Bellin-Ambrosio. We can see no posterior elevation in the lower right bottom picture. And this was the wavefront. The coma aberrations is 0.24 with a normal, and the spherical aberrations 0.32 again with a normal. So finally, it's important to differentiate or to give a differential diagnosis for what we see between post-Lasik ectasia and the decentered ablation. And of course, the keratoconus, but the keratoconus, it has no history of LASIK, so it's out of our differential diagnosis. So decentered ablation and the post-Lasik ectasia patient, they will be coming to you having the same complaints of high order aberrations like glare, ghost images, but maybe the progressive part is not present in the decentered ablation. So we have to differentiate between both of them. First of all, how to detect the ablation edge. Ablation edge is easy to identify on the tangential map. The myopic ablation edge has a warm color, and it will be called color in the hyperopic ablation. This red-blue ring should be identified in relation to the pupil edge, and we have to identify the amount of the decentration, because if it's more than 1 millimeter, they will be troublesome. Elevation maps, again, it's essential to exclude the posterior elevation related to post-Lasik ectasia. So the main element that differs the post-Lasik ectasia from the decentered ablation is the posterior elevation, but they may have the same picture on the sagittal map. For example, this is a case of post-Lasik ablation, but we can see here there is a central flat area of ablation. The Q value is plus 1.39. Central flat cornea surrounding the pupil. There is no decentration. Anterior elevation is minus 13. There is no posterior elevation. There is a thinning, which is expected. So this is a case of normal post-Lasik myopic ablation. So we come to this example. We can see by looking at the anterior sagittal map, we can see that the circular ablation area is almost at the edge of the pupil. The pupil is the dotted circle. So I think this is like more than 2 millimeters of the decentration from the pupil margin. We can see that the peripheral area here, or the red-blue ring margin, with the keratometry 47. But I can get confused between this and the post-Lasik ectasia. But by looking at the elevation, there is no corresponding elevation at the area of the high keratometric readings. And the Q value as well is not high minus. It's again plus 0.42. And this is another example of decentered ablation. The same example. I can identify the margin related to the pupil, no posterior elevation. So we finished our part. Now I'm going to move to Dr. Mohamed.
Thank you, Ahmed.
Mohamed, you can. Thank you.
Okay. Thank you, Ahmed. I think we had a longer time with Ahmed's presentation, but it was intended for the young doctors who are attending our meeting to be careful when selecting their cases for LASIK first. And second, to review all the investigations before doing LASIK, and to consult with all your colleagues before you start a LASIK case. How to act, what to do with when you are confronted with a case of post-Lasik ectasia. First thing that I learned from my colleague, Professor Mohamed El-Sebaey, don't accuse the surgeon, because the patient's coming to you angry and you don't have all the data before surgery. You don't know anything. So just calm the patient and start managing him. In our study we conducted in our department of ophthalmology, Professor Karim, God bless him, was the main investigator, Professor Higazi, me, and Walid Ghubashi, our colleague. And we are continuing the study till now, because we have a lot of cases that we are following up in this study. So we were confronted with a lot of cases of post-Lasik ectasia. We selected 24 eyes. They were divided to two groups. One of them we had glasses and, first we did the cross-linking and correction of the error with glasses. The second group we had cross-linking and correction of the error with RGPs, the Egyptian one, the RGPs, the Egyptian one. The post-intervention results was so much remarkable that the group 2 that had the RGPs had best corrected vision improvement between 0.5 to 0.9, and with all satisfied, while the group 1 that were had only glasses, the best corrected vision they could reach was 0.5. So the message to take home for these cases is that don't worry if you have a case of post-Lasik ectasia. First, do the cross-linking, try to stabilize the error with glasses, and then if it doesn't fit, go to the other thing, which is the RGPs. There are different treatment modalities I'm going to review over the internet, like glasses, cross-linking glasses, cross-linking and RGPs, cross-linking tomographic guided PTK, and other modification like the dark, cross-linking and intraocular lenses, or cross-linking corneal rings. And actually, I had all these cases that I was confronted with, and all these patients are not satisfied. And I think for all the cases we reviewed are either you go for RGPs, and if the patient is not satisfied with the RGPs, the keratoplasty will help. And I had a lot of series of cases that I referred to Professor Mohamed El-Sebaey. They had keratoplasty, they are so much satisfied, especially that these eyes that were not keratoconus did not develop this high aerostigmatism that happens with penetrating keratoplasty with the cases that are actually keratoconus. The cross-linking in ectatic post-Lasik cases, you have two choices. Either the old protocol where we remove the epithelium and then the epi on, and that was different techniques. But actually, the problem with cross-linking, if you have a thin cornea, you have to do cross-linking with a thin cornea. So maybe the only way is to use a hypoosmolar riboflavin. You could use a contact lens, and sometimes they use a lenticule from a case of smile to put it over the cornea to protect the endothelium while cross-linking. So the take-home message from this study to you is first, Lasik patient is a normal patient. So be very careful in selecting your case, consult with your colleagues, and be careful while doing the calculations like Ahmed was presenting, because do your calculations once and twice before going to start. So, and use always a new blade. The other thing to take care of is to read the pentacam map. It is not a color map. There are numbers in this pentacam map that a lot of us maybe miss. So read the numbers carefully. And the other thing, if you feel there is a borderline case and you are not so much satisfied with, there is no shame to tell the patient that you are not fit for Lasik and you prefer another procedure for him. This photo just for the young generation to know, if you put an RGP on a patient, this is how the fluorescein should look like for the best corrected vision. So lastly, I'd like to God bless the soul of Professor Karim Kolkela, who was with us in this study. Professor Karim was supposing that we continue our study and involving the corneal biomechanics. That's what we are doing now. We are studying all these cases with the corneal effect of involving the corneal biomechanics with our study, and hopefully we'll publish it next year. Okay, thank you.
Thank you very much, Dr. Mohamed El-Sebaey. Thank you very much.
أشكرك يا دكتورة ميرفت، لأن الجزء الأولاني من البرزنتيشن إحنا لخصنا المحاضرات بتاع دكتور مازن.
تمام بالظبط.
فدكتورة ميرفت كانت يعني دكتور مازن كان عمل 3 فيديوز كانوا very interesting very informative. فاحنا حاولنا انا واحمد ان احنا نوصل المسج اللي كانوا في الثلاثه فيديوز دول في الفيرست بارت اوف اور برزنتيشن.
Thank you very much, Dr. Mohamed. Very interesting, actually, and informative session or the presentation. Both of you made a lot for us now. I think all of us enjoyed very much about the Post-Lasik Ectasia. Actually, for our audience, we use term Egyptian English language Ectasia, but actually, if you are going to be international, it's a Post-Lasik Ectasia.
Yeah.
So I want to thank you very much, Dr. Mohamed. Let me.
Can I just make a small comment, please?
Yeah.
Of course, yes.
Okay. أولاً أحب I would like to congratulate Dr. Ahmed Rashid for the wonderful, really wonderful review and comprehensive, detailed presentation about this serious issue. Just one thing that I would like to add in the predisposing factors of ectasia, which is hyperthyroidism. Be careful of patients with disrupted rhythm of thyroid gland. This is horrible. الحقيقة الدكتور أحمد المصري، الأستاذ الدكتور أحمد المصري من جامعة اسكندرية, a very nice presentation about this. And I have faced a very rare case of ectasia after 15 years or 16 years. Doctor, she developed ectasia after 15 or 16 years when she developed a hormonal disturbance of thyroid gland. So be careful of thyroid gland. Sometimes it's a trigger factor in ectasia. Something else which is very easy to add for our young colleagues. There is a simple question that we ask every day in the exams of the master degree. When you have two patients at the same age, 33 years, they are intellectual and they never wore glasses. One of them, you tell him, come and I will do you LASIK, and the other one, you tell him, no, you have keratoconus and we have to do cross-linking as urgent as possible without having pentacam. In your clinic, you can detect and you can pick a case of keratoconus without using the pentacam from several criteria that you have in your clinic, like the best corrected visual acuity, the axis of astigmatism, the interrogatism, the mirror image of axes, the history of the patient when he tells you that I have been I was supposed to be wearing glasses when I was 16, but I refused them. And the other one will tell you that I had very sharp vision until very near, very recently. So this patient is probably a keratoconus. When you go to make pentacam in the center, then you have an idea of scoring in your head that this patient or this patient is suitable or not suitable for LASIK surgery. الحقيقة أنا كنت in debate مع أخويا وحبيبي الأستاذ الدكتور أسامة المحراوي about PRK. And he showed me that the General Medical Council, the British General Medical Council, allows PRK until -8 diopters. So don't hesitate. Once you have any doubt, go for PRK and do it. Even up to -8 diopters, it's suitable. I don't do PRK up to -8, but it is viable to up to -8 and accorded for this. Last thing, be careful, because once you do any kind of surgery in the cornea, the instrument that you are using, whether it's laser, knife, whatever, it doesn't have an eraser on the other side. It just, you will make the mark and it will never go. So be careful and think twice before going for LASIK surgery. Thank you. أنا آسف للطول.
لا شكرا محمود.
Thank you, Dr.
محمود. الحقيقة thank you all and thank you my colleague and friend Dr. Mohamed El-Sebaey. I want to are all grateful to our boss, Professor Karim Kulkila, rest in peace, and may God bless him and his soul, because actually his contribution to our work and research is still now, and I think will be followed us many years, inshallah, upcoming years. Thank you, Ahmed, very much about your informative, comprehensive talk, as Professor Mahmoud said now. And thank you, Dr. Mahmoud, for your very important, actually, notes now. And we have some questions from the audience. We start with the first one. How can you know that abnormal shape is true or false? How can you know that abnormal shape is true or false? And is pentacam more informative than Orbiscan?
To answer, أنا أحمد هجاوب على الأولاني، بس أنا هجاوب على الثاني بالنسبة للبنتاكام. دكتور في some professors are mastering Orbiscan, like Dr. Khalid Nagi of Tanta. He trusts Orbiscan over pentacam. So whatever tool you are so much trained on, you understand it very well, use it as your benchmark for selecting your patients. تفضل يا أحمد.
Okay, regarding his yes, can you hear me?
Yes.
Okay. So regarding the first question, he was asking about how to know the abnormal shape is normal or abnormal. I don't understand the question.
Okay, yes, please, Ahmed, raise your voice. Dr. Khalid Zaki, you are one of our panelists. Please, you can ask by any way, another way. Can you know about normal shape, true or false, from what? If you hear me, please.
طب في أسئلة تانية دكتورة ميرفت؟
Yes. How can we do cross-linking in post-Lasik Ectasia at residual stromal bed less than 400 microns?
I had it in my presentation. If you have less than 400 micron, you could use contact lens, or as I said, the lenticule from a smile case, or you could use a less concentration of the riboflavin with less power of the cross-linking machine.
Okay. Thank you very much. I think there are no more any questions. I think there's here in this box.
Okay,
yes,
I can answer Dr. Khalid according to what I understand from his question. يعني هحاول أجاوب على قد ما فهمت. تمام. طيب اوكي. طيب مثلا يعني هو if you suspect an abnormal shape in the tangential map, for example, or in the posterior elevation map like this one, Okay, like this one. If you because I see in many cases a tongue-like extension like this, but the cornea is normal. You cannot rely on only one finding. As I said before, you have a group of criteria of a keratoconus, like abnormal topography, with the thinning, with poor vision, with a posterior elevation, and maybe anterior elevation. For example, if you can see the tongue-like extension or the skewed hourglass, you can suspect a misalignment, or you can suspect a tear film abnormalities. Tear film abnormalities or the dry eye, this can be evident by not finding other risk factors and by the slit lamp examination. Misalignment, you can exclude it by repeating the examination. This is one cause. The other cause of the skewed hourglass, it is the large angle kappa. If you have a patient with a large angle kappa, you can have a skewed hourglass and his cornea is completely normal. Another cause for this abnormality, as I said, there is a noise.
Ahmed, please, our audience, if anyone open the microphone, please, or mic, close it, please, to let our speaker tell us about the answers of questions.
Okay, so I think I have answered most of his.
Yes, okay. I think Dr. Ahmed, also we have to include when you face an abnormal map, you are not sure that this is a pre-ectasia or this is an early keratoconus or just an abnormal cornea. There is a kind of abnormal corneas around us, and we don't treat them with laser, but we are following up them. And these abnormal corneas, they end by not being a keratoconus at the end. Some of them, you have to be very thoroughly examining the cornea. Some of them, and a lot of them, they have faint opacities or panas in one way or another that develop abnormal corneas. So they look like rare corneas and rare bizarre topography, or even they have higher order aberration somehow not coinciding with the map that you have. So in these cases, you just look carefully on the cornea. You probably will find your answer, clinically examining in the slit lamp.
Yes, yes. Thank you, Dr. Mahmoud.
Thank you very much, Ahmed. Thank you, Dr. Mahmoud.
الحقيقة أحمد قال نقطة مهمة يا دكتورة ميرفت. very interesting point. الحقيقة دكتور أحمد قال إن you don't look only into the map, and this is very serious.
I want to tell that now. Oh, yes.
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 My professor Jorge Alio, he has a very, very nice example, and he says,
yes,
the patient elect for LASIK is like a student in the final exam of his final year exam. You might forgive him in one subject, but two subjects he fails and he has to repeat the year. So يعني لو هو طالب في بكالوريوس وعنده مادة واحدة على الحروكروك ممكن ناخد رأفة. يعني لو في thickness قليل we can do PRK. We have high curvature, we can do PRK. If she's young, female, 19 years, and everything is okay with her, but this is a very it's a high risk factor to do her LASIK, we can do PRK. But two factors of high risk, no LASIK in this moment.
Yes. Thank you very
ودي
much.
نقطة الحقيقة أحمد راشد لمحها ومهمة أوي. البيشنت مش بنتاكام، العيان مش it's not only بنتاكام.
Clinical correlation بروفيسور محمود we have clinical يعني مش كلها imaging، مش just imaging. It's a multiple criteria